And
recording in progress.
If there's something that needs to be tweaked, if we need to sort of change course, change direction, really having that sort of tight oversight helps you to, and that's the beauty of implementation study, where you can basically make changes that are going to make the same rules of an efficacy trial. Okay, awesome. Thank you, Jess. So let's see. All right, it's just warming up here. But yes, I can go through this while it's up. So this is our recruitment graph. The yellow line is our target. The red line is what we sort of aimed to do. If everything were to go perfectly and we were to recruit just as we had planned, it would have been that straight red line. But the blue line is the actual line. And everyone who does this work can relate to this, where you start slow and where you're sort of, figuring things out. And we had a lot to figure out. But the Community Health Action of Staten Island and the community health workers there were incredible at just working with us and helping us to really figure out what we needed to do. You'll notice that right about March, we have an inflection point where the slope really started, really sort of went to where the slope should have been from the beginning. And that's the point at which we changed our incentive as well as our recruitment strategy. Number one, to not just focus on people who were inside of the barbershop, but to expand it a little bit more, to really take advantage of the connection that CHWs has in the community. They're all over Staten Island. And so we said, well, if there are barbershops that are smaller, that are not getting as much traffic as we would like, why don't we leverage some of the community activities that are happening and just measure blood pressure at those health fairs or what have you, and ask the people that we're measuring, whose blood pressure we're measuring, do you attend Joe's Barbershop? We're in Joe's Barbershop recruiting right now. And if you can meet us there on Monday, we have this $30 gift card. If you're eligible, for the study, you decide to participate. It's just filling out a survey. We can really keep an eye. We can help you to monitor your blood pressure and hopefully help prevent you from developing hypertension, which is the #1 killer of Black men. Tanisha gives a much better spiel than that, but we found that the combination of opening up our strategy as well as changing the incentive from what it was originally, which was a free haircut valued at $30. There are some people in the room who remember when we were giving vouchers for $20, where the $20 included the cost of a haircut and a tip. That's just to date some of us. But now, that's increased by 30%. So what we decided was, okay, that incentive worked, back in the 2010s. Let's change it up a little bit. And so we actually changed from the incentive of basically allowing the men to be entitled to a haircut to saying, here's $30 for you to spend however you want to. And that actually made a huge difference. And so you can see that we learned a little bit more with each cohort. And by the end, we have that beautiful slope that got us to our target. So this is basically the enrolled, the not enrolled, and the total screen for each shop. So I really love this graphic. So the green line is how many people we screened in each shop, and the orange line is how many people were enrolled. And overall, you see we had a pretty good learning curve where we were able to screen more people. probably due to the fact that we got better at approaching people, and we got our spiel down, and all of those things. But we also had a pretty impressive closing rate by the end as well. So we can just take this in. But what you'll notice is that we actually enrolled 22 shops rather than 20 shops. And that was because one of our shops decided, and those who've done barbershop work with me will know this is a very common scenario, where we all but got sort of kicked out of the shop, right? Where they decided that despite like us telling them everything that it was going to entail, we ended up being more of a nuisance than they had planned on. And they didn't like explicitly kick us out, but it was sort of passive aggressive, where we were like, okay, they're not referring any of their barbershop customers to us. Like, let's just like cut our losses. And so what we did was, so we actually figured that out relatively early on in the baseline enrollment period, which, as I mentioned, was 3 months. So basically, 4 or 5 weeks in, we're like, this is not working. So our community health workers actually, they identified another shop, essentially, that we could sort of move into that slot, basically. But we had enrolled enough men from the shop that was kicking us out that we basically kept that shop and said, we don't have to be in the barbershop to get the follow-up data. We can call them on the phone. We can meet them in other places. So we decided to keep that shop, but to just add a 5th shop to that cohort. And so to sort of balance things, we basically had to have another 5-shop cohort. And so we had 3 4-shop cohorts and 2 5-shop cohorts, and that's how we get to 22. Did I explain that right? Okay, cool. Let me see. It's trying to update. I'm not going to let it. All right. So this is our expected, our actual versus expected enrollees by cohort. So you'll notice that the yellow bar is the same for each cohort. We had planned to enroll 20 men per barbershop, which equals 80 men per cohort. And you can see that in the first cohort, we were way below where we wanted to be, but we improved, where by the end, we were really kicking butt. So we're really proud of this learning curve, and just a lot of hard work, and us just staying on the CHWs who it's amazing that they haven't kicked us out, because we just every week we're like, we know that you're working really hard and trying to do everything that we're asking you to do, but we need more. And so we're always aware of how much we're asking them to do, but this is research. Like we sort of have to do what we have to do. But that just speaks to how important it is to have a partner who's willing to sort of really go on this journey with you, and we've been very fortunate to have that in Staten Island. All right, so we do have some baseline characteristics. So we have a wonderful baseline data set, basically, of 430 men. And so, as you can see, right at the right age group, for people who have elevated blood pressure, we probably expect this to be a little bit higher age if we were focused on people with hypertension. And so, as you can see, we have a really good number of people who identify as Hispanic and Black. And so that is a group of people that is just not really talked about in the literature, in the hypertension literature, especially. In the hypertension world, we've been, unfortunately, very binary, and have focused largely on non-Hispanic Black adults. But more recently, there has been an appreciation of both the heterogeneity within Black adults, but also within Hispanic adults as well. And so we're seeing, more and more that studies are starting to disaggregate Black populations as well as Hispanic populations. But still, there's so much more that needs to be done on this particular group. The people who identify as both Hispanic and Black. And we're very fortunate that we actually have that. We have a good number of those folks. And one of our fellows for the Restore Network, Dr. Mila Arabajian, who's at LISM, she's actually really focusing on what we can learn from these patients we have, from these participants we have included in our study. So the blood pressure is sort of, basically right in the zone that we want it to be. And some more baseline data. This is the education level. The majority are high school graduates. So some have college, but the majority are those with high school or GED. And then you see the employment numbers here. So yeah, which is not unexpected for the age group that we have focused on. Marital status here, relatively low percentage of people who are married. And then the household income you see, those who do decide to report are mostly those who make less than $50,000 a year. But this was a question that the most men chose not to answer. We wish that we could have done better with that. But that's definitely a sensitive question to ask. So the majority of our over half of the men reported having health insurance, but a very small number report having a primary care provider, even though half of them have a usual place of care. So how are we doing with follow-up? We have 3. And so just super quickly. These are some of our power calculations. Basically, what this tells us is in order for us to have 80% power to analyze our primary outcomes, we basically need to retain about 70%. So 300 divided by 420 is roughly 70%. So if we're able to do that, we will have pretty good power for all of our primary outcomes. And so this is how we're doing with 6-month follow-up. And I should mention that our primary outcome is 12-month follow-up. 6-month follow-up, it would be wonderful if we got everyone for that. Really, those are to help us interpret what we see at the 12 months to see, if someone went from a systolic of 120 to 140, right? What happened in that 12 months? Did they, was it just a straight shot up? Did they go down and then go back up? Did they go up and then come down? That's what the 6-month data point helps us to do, just to sort of see the trajectory of the blood pressure. And as you can see, so the number that we pay attention to mostly is the participants who have exited the window. That means that we have basically lost them for that follow-up data point. And at the time that we made this table about a month ago, 38%. We were losing 38%, and that's actually an improvement from where we had been in the past. And we're learning that it's very challenging to keep up with some of these participants. But we actually took this as a very good signal for what kind of success are we going to have when we try to get them for 12 months. And so for those people that we had trouble getting at the 6-month period, Tanisha had the brilliant insight that those are people that we really, that basically that is a signal. And what they're saying is, I'm going to be really hard to reach at 12 months. And so we actually devoted extra energy to those people. And actually for the 12-month follow-up, we actually improved that markedly, where at the time that we made this graph, we had gotten down to only losing about 14%. And so, you know, we know that we have a long ways to go, but you know, but that insight was actually very helpful. In addition, just wanted to show this graph here. So we started follow-up, 6-month follow-up in June of 2023. 6-month follow-up is the red line. 12-month follow-up is the blue line. And so, you know, as you can see, 6-month follow-up actually got up, you know, to almost 50% at one point. And then the 12-month follow-up, you know, had also gotten quite high. And it was at this point that we realized that we need to have someone, that we need more people on deck. And actually, we actually hired 2 new people, and one of which, Nielis Garcia, who couldn't be here today, but she is what we call our follow-up specialist. She is like, her job is really to focus on follow-ups. And we think that made a huge difference, as you can see, when Nielis started, you know, it's continued to go up a bit, but sort of once we had her fully integrated, we can see that it really started to come down. So I encourage all of you, as you're writing your grants, to write in a follow-up specialist because it is really important, particularly for this kind of work. So. And then 18-month follow-up. At the time that we made this table about a month ago, we had just started 18-month follow-up, and we were doing pretty well. We've lost a few since then, but we're still doing pretty well with 18-month follow-up. Oh, okay. So I'm sure many of you are wondering, how do we keep engaged with the men after they are enrolled in the study? CHWs continues to engage them both by phone and in person when possible, with monthly check-ins with enrolled participants, where they review Life's Essential 8. This is the American Heart Association, basically, you know, the essential 8 factors that everyone should sort of focus on for optimal cardiovascular health. It used to be Life Simple 7. It's now Life's Essential 8. Just to go around, starting at the green. So healthy eating, physical activity, healthy blood sugar, healthy weight, healthy lipids, healthy blood pressure, don't smoke, and get enough sleep. Those are sort of the 8 things that if you do that, you'll optimize your cardiovascular health. So the community health workers review that every single month with the participants who are enrolled. They assess any needs that they have for clinical or social referrals, and then importantly, they give them heads up to say, hey, you know, I talked to you 3 months ago. Sorry, you enrolled 3 months ago. Coming up, you have a 6-month follow-up. Let's make, you know, so expect that I'm going to call next month, but I really want you to just keep an eye on that 6-month follow-up, because I'm going to be calling you. You need to come in to get your blood pressure measured, and if you do, there's a $30 gift card waiting for you. All right, and these are some pictures of Tanisha and I out engaging with the Staten Island Office of the Borough President. So we went there on the day that they were getting, that they were recognizing the American Heart Association 100 years. So that's the Staten Island Borough President with Robin Vitale, who is one of the leaders of the New York City office of the American Heart Association. There's us in out in the community measuring blood pressure, and and then these are us. This is Tanisha doing CPR training with some of our community partners. And if you know Tanisha, she's not going to let this mannequin die. So, all right. Oh, sorry. So that was supposed to be one of the posters that we presented at American Heart back in was it March, Tanisha? So sorry that didn't come out the way that I hoped it would. But this is another poster that we presented that really focusing on some of the differences that we're seeing with what we're calling the Afro-Latin members of our study compared to the non-Hispanic Black men. And that'll be the subject of another talk. And then, as we think about sustainability, we've been talking to partners around the city about this 1115 waiver. I'm not sure if any of you have heard of it, but basically, it is a way that Medicaid and Medicare will be reimbursing for us as healthcare providers addressing health-related social needs. And so they're doing this 1115 waiver is sort of a pilot program for this. And the way that the federal government is distributing the money is through what they're calling these the social determinants of health networks. And so there is a community-based organization that is basically receiving the money and then sort of doling it out to various community-based organizations that are actually addressing some of those social needs, such as food insecurity, housing insecurity, other really important social determinants. And so the reason that I highlight this is because the PPS, which is one of our what we call sustainability partners, the PPS who is working with us and our study, they are actually the hub that's going to be distributing money in Staten Island to help address social health-related social needs. And so just to emphasize that we are definitely have the right partners for this, as we think about how we can sustain some of the things that we have done. So some of the challenges that we are facing really with regard to follow-up are that participants are reluctant to answer unknown phone numbers. So we sometimes get, have gotten hung up on multiple times, but once they see a number that they know, and even CHWs has been great about calling from their personal numbers, because the CHWs and CHWs often know many of these men. Changed or disconnected numbers is really a really tough problem, as we know. That's why we collect multiple phone numbers when we are enrolling participants, but it is still a challenge. With the migrant crisis that we saw at the end of last year, we definitely have more. We noticed sort of more housing unstable individuals that were being enrolled as participants, but that really speaks to who CHWs is. They turn no one away, and that's one of the things that we love about working with them. But it can make following someone for 18 months a challenge. So one of the things that we have tried to do with CHWs is to see, can we utilize their CHWs offices as places that the community sees as safe spaces, but can we have some of the participants come in to get their follow-ups there? And so, CHWs has been great about really, helping us to figure out solutions to some of these challenges that include offering follow-up appointments at the CHWs offices. CHWs has a van that they can park in front of barbershops and really go anywhere in the community to try to find participants who have already enrolled in the study. And so, all of those things, in addition to having Nyalis work incredibly closely with them, we think has all really, really helped. We are actually doing quite well, where we actually have enrolled all 22 of our shops, all 430 men, with enough time left in the study to be able to do 18-month follow-up before the grant ends in September 2025. And so, and I think that we're the only study in the network to actually be able to do that. So we're really proud of having been able to be successful with recruitment in time to do the long-term follow-up that we planned. I think that's it. So we're going to continue to focus on follow-up. We actually have, with this wonderful data set of 430 men, we actually have the ability to start turning out papers. So we are hoping to do that. So anyone who's interested, let us know. And then also looking to really think about how we can leverage what's happening with health-related social needs reimbursement around the city, so that when September 2025 comes, we have something that we can transition into, and we don't have to abandon everything that we have worked so hard to build. I think I'm going to stop talking, but thank you all for your time and attention, and open up for questions. But Tanisha, I don't know if you have anything to add.
I was in Malcolm down, Joe in Malcolm down. So he knew that he was going out to Staten Island and trying to move to that, specific to that though. He's a little bit isolated from the rest of New York. And so having him at Staten be our partner was the best recipe for success with this.
Thank you. Any questions or comments? Yes, absolutely.
Impressive. Recruitment's always the hardest part, so.
Thank you, Joe. Thank you.
Pivoting a couple of times to get that line to get to the right place.
Yeah.
I'm impressed that you started early, right? So this is before hypertension. So it's quite interesting and important.
Mm-hmm.
So the majority of people.
Yes.
I'm intrigued by, you're focusing on life's essential needs. What do you tell them? Can you tell me a little more? And how is it going? And what's your feel of, like, and how are you going to assess whether people are making these changes? Because in a way, it's just the right thing.
Yeah. So great question. We think it's going well. We have worked on a script with the community health workers, who call these men monthly. Not totally sure about how it's being received, other than qualitatively, but according to the CHWs, they're able to they actually stay on the phone. The participants stay on the phone. The only way that we'll be able to really assess, how they're doing with some of these behaviors is through the follow-up questionnaires, which we do ask them about some of those behaviors, but we're not objectively measuring any of them. In part because this, because this is not an efficacy study, we weren't really focused on, on that part of the intervention. What we're really focusing on is the facilitation, that's happening in the intervention shops versus the control shops. So, and so it'll be sort of, interesting to see what we get at the end, and if we get enough information from the surveys, to be able to at least have a self-reported sense of sort of, of the impact of this. So, but totally fair question. If it would have been great to have had the resources to be able to more objectively measure some of these things, like, sleep, for instance, or, other, other lifestyle components of the life's essential aid. But yeah, it's basically self-reported measures of that.
So yeah, we do ask self-reported sleep and baseline 6, 7, 18 months. We ask about eating, with Mediterranean activity, physical activity. We do ask baseline 6, 12, and 18 months, so we can certainly measure that they self-reported.
Even as you say, getting in, being able to include building routine, building mechanism is so important. And then in the ongoing study is part of the self-report, which maybe leads to a second question if you have time.
Yeah.
Some friends have thought about whether people would be interested in also taking like a diuretic, low cost, low risk, may get you before the hypertension. And what your thoughts are about that as the next study has.
Yeah, so I mean, certainly the trophy study, of course, demonstrates that that there can be benefit to to treating pre-hypertension when it comes to preventing hypertension. So diuretics are a bit of a tricky one. Absolutely low cost, absolutely effective, but maybe one of the least favorite drugs for men because of the side effect of erectile dysfunction, which I've just heard from a lot of people who take it. So I love the idea of it, but could we think about a drug that is more friendly than diuretics? We're certainly talking about probably higher costs. We're talking about other potential side effects, but my sort of my algorithm for treating hypertension is put folks right on amlodipine and benazepril combo pill, and add the diuretic if it's still not controlled, but it's definitely sort of lower on my list. If you two things will guarantee that people don't take their medications, make them expensive, and make them have side effects. So, but I do think that study's coming. Especially given some of the things that you've talked about and worked on, where it's pretty convincing that lower is better, period. So yeah.
But I had a question on the implementation. But for the pre-implementation phase, I think you mentioned that the strategy for the implementation, or the approach for the implementation strategy was like informed by the findings and research. But I was curious if there are any other strategies or approaches to develop that.
Yeah, so and so in that first year, we met with a group of stakeholders monthly, to really sort of to talk about not only what we're going to do, but how can we come up with something that that the barbers would accept and want to sort of, implement over the long term. And so it not only involved, us, meeting monthly, but us actually going out to several barbershops. As we not only wanted to get people familiar with the study, but also to use that to get information from the stakeholder who matters most. And so they were really important in helping us to inform what a sort of workable workflow looks like. There's also an opportunity for us to, to say, hey, we're going to be coming back to see if you will participate, in the next phase of the study. Thank you. All right, hey. Great question. Yes, yes. Yeah, great question. The short answer is, so we have basically two community health workers who are basically full-time on this study. One of them identifies as Afro-Latin and is Spanish speaking. And actually he is our second one because Ovali actually Ovali started, he transitioned off, and Andres started. But they were instrumental in helping us to work with the shops that cater to Afro-Latin men. And even though all of the study materials are in English, and we we did not translate all the instruments into Spanish. We just didn't have the time or the resources to do that. And so it is a requirement that everyone who participates in the study speak English. We likely would not have gotten the majority of the men to even, participate in the study had it not been for Ovali and Andres being able to make connections in their primary. So would you? Yeah.
But I will say this, when you look at the numbers, most of the Afro-Latin men, they're very interested. Obviously, it's still a ethnicity. So they would do in here, and I think that really taking English with other things. But we also have Maryland who is Afro-Latin. As our retention specialist, so that helps out with really even if they speak English, it's nice when it's call them to use her name, and they're like, yeah, I'm going to call her then. And they might get questions.
Thank you for that question. All right. Well, I appreciate you all staying a whole extra 7 minutes. All right, and happy to answer any questions, and if you have interest in working with our baseline data set, give me a call.
Who would the contact be?
They can email me directly. Yeah.